This is Barry Zalma on insurance. I am an attorney who has retired from the practice of law and now spend my time as an insurance claims consultant and expert witness, and author and producer of these videos. Today I'd like to talk about measuring the health effects of mold as part and parcel of insurance claims relating to mold. And we'll begin with medical evaluation. When a person claims illness or injury from mold or fungi, individuals with persistent health problems that appear to be related to fungi or other bioaerosol exposure should see their physicians for a referral to practitioners who are trained in occupational or environmental medicine or related specialties and are knowledgeable about these types of exposures. Infants less than 12 months old who are experiencing non-traumatic nosebleeds or are residing in dwellings with damp or moldy conditions should receive a medical evaluation to screen for alveolar hemorrhaging. Following this evaluation, infants who are suspected of having alveolar hemorrhaging should be referred to a pediatric pulmonologist. Infants diagnosed with pulmonary hemosiderosis and or pulmonary hemorrhaging should not be returned to dwellings until remediation and air testing are completed and toxicity is eliminated. Clinical tests that can determine the source, place, or time of exposure to fungi or their byproducts are not currently available. Antibodies developed by exposed persons to fungal agents can only document the exposure has occurred. Since exposure to fungi routinely occurs in both outdoor and indoor environments, this information is of limited value. Mold allergies are fairly common. A mold allergy causes a person's immune system to overreact when mold spores are breathed into the lungs. A cascade of reactions then leads to allergy symptoms. Like all allergies, a mold allergy can cause coughs, make eyes itch, or cause other symptoms that make the allergic person miserable. The best defense to a mold allergy is to reduce the exposure to the types of mold that cause the reaction. While it isn't always possible to avoid mold allergy triggers, medications can help keep mold allergy reactions under control. Although a mold allergy is the most common problem caused by exposure to mold, mold can cause illness without causing an allergic reaction. Mold can also cause infections. Infections caused by mold can cause a variety of problems, from flu-like symptoms to skin infections and even pneumonia. An irritant reaction is caused when substances from molds, called volatile organic compounds, irritate the mucous membranes in the body. Symptoms of an irritant reaction are similar to an allergy and include eye irritation, runny nose, cough, voice hoarseness, headache, and skin irritation. When a mold allergy symptoms, according to the Mayo Clinic, generally get progressively worse with each exposure to mold. An irritant reaction, on the other hand, does not get worse. The best treatment for any allergy is to avoid exposure to the mold that triggers the allergic reaction. Molds are common and cannot be completely avoided. There is no way to cure a mold allergy. At best, symptoms can be partially relieved with some drugs like antihistamines. Relocating people away from infested locations is usually unnecessary. Only people who have compromised immune systems, like infants, and people with AIDS should be removed from the infested location. Others should strongly consider relocating, including people with asthma, hypersensitivity pneumonitis, severe allergies, sinusitis, or other chronic lung diseases. There is almost no reason for otherwise healthy individuals to evacuate a building without the recommendation of a professional just because mold is observed. Remember, mold is ubiquitous. It's everywhere. There are millions of different kinds of molds and fungi. So when you do a test for mold, that test must be evaluated by a professional. The levels of fungal organisms in a structure or outdoors vary by several orders of magnitude during the course of a day due to activity levels in the area and other factors like fluctuations in temperature or humidity that can cause the release of spores. The spores may no longer be viable, and though allergenic, they will not grow on any media. Concerns should be raised and investigations conducted if total indoor counts are greater than outdoor fungal counts, comparing indoor and outdoor ratios. This comparison is not valid when the outdoor sample was taken during or immediately after precipitation, because rain will wash away some of the mold spores. It probably is not valid during some winter months, where outdoor fungal counts are usually below that indoors. Comparison of indoor and outdoor levels of fungal organisms shows one of the following. 1. Organisms are present in the indoor sample and not in the outdoor sample. 2. The predominant organism found in the indoor sample is different than the predominant organism in the outdoor sample. Or 3. A monoculture of an organism is found in the indoor sample. The organism is capable of producing a carcinogen, such as aflatoxin produced by Aspergillus flavus. There are often problems finding a causal relationship by environmental exposure or an allergy test. The antigenic material produced by a fungus varies, and establishing a direct link between environmental exposure and the results of an allergy test is seldom definitive. To comply with the Americans with Disabilities Act, certain changes such as increased filtration of the air can be made to further reduce levels where an individual has been diagnosed by a physician as allergic to a specific fungal organism, even if test levels are not identified as a problem. Removal of the person from the area is often the most successful approach to determine if there is a causal relationship. If the symptoms disappear, there may be a relationship. When test results come back, there may be a problem if the numbers are high. Fungi indoors are different from outdoors or non-compliant controls. The fungi are allergenic or toxic. The area is likely to be disturbed. There is or was a source of water or high relative humidity. People are occupying the area or have contact with air from this location, and there are immune-compromised individuals or individuals with elevated sensitivity to mold. Researchers have not yet found reliable biomarkers for human exposure to indoor molds. Biomarkers do exist for the presence of some mycotoxins, produced by the ingestion of moldy foods, such as aflatoxin, but those biomarkers do not necessarily apply when inhalation is the exposure route. The Environmental Protection Agency published a report on the needs for research on indoor environments and concluded that standardized and quantitative methods to assess mold exposure are important efforts, which should include studies to establish biomarkers of exposure to mold in humans or surrogate biomarkers in order to assist researchers and medical personnel in assessing mold exposures. Research should identify patterns of cross-reactivity among fungal allergens and the relative potency of different antigens. To date, there is no report of the results of the recommended research. Even more rapidly expanding than property damage caused by mold are claims for bodily injury caused by the inhalation of various mold spores. Plaintiffs claim that they and their property were exposed to molds, fungi, and other substances in their homes and workplaces. As a result of the exposure, the plaintiffs claim that they have incurred personal injuries. Some people claim they are victims of a sick building. The Environmental Protection Agency describes the claims as sick building syndrome. The term sick building syndrome is used to describe situations in which building occupants experience acute health and discomfort effects that appear to be linked to time spent in a building, but no specific illness or cause can be identified. The complaints may be localized in a particular room or zone, or may be widespread throughout the building. In contrast, the term building-related illness is used when symptoms of diagnosable illness are identified and can be attributed directly to airborne building contaminants. Frequently, problems result when a building is operated or maintained in a manner that is inconsistent with its original design or prescribed operating procedures. Sometimes indoor air problems are a result of poor building design or occupant activities. For more than 30 years, health problems attributed to building-related biological and non-biological materials has been on the rise. Indoor air quality professionals and consumers have unfortunately lacked a starting point from which to compare bacterial and fungal bioaerosol results in a presently unregulated industry. At the 2005 American Industrial Hygiene Conference Expo in Anaheim, California, Dr. Rajiv Sahay announced the results of a decade-long study on airborne culturable bioaerosols in a presentation entitled Indoor Environmental Quality. Although the report is not definitive, it is a beginning from which other studies may finally put to rest the question of whether fungi are sufficiently toxic to cause bodily injury. To complete the study, the authors gathered information from building investigators who had collected air samples from various buildings around the United States from 1995 to 2004. As a part of the study, a total of 5,344 samples were collected from 3,464 different test sites belonging to 570 buildings across the United States. The collected specimens were cultured and identified. During the same period, more samples were taken. When the concentration of fungi was analyzed for outdoor versus indoor samples, a ratio of approximately 3.1 was noticed in the case of both commercial and residential buildings. On September 30, 2004, the University of Connecticut Health Center Division of Occupational Environmental Medicine and Center for Indoor Environments and Health issued a report to the EPA. The EPA made comments and suggestions on the report. The authors found that there is strong evidence that significant disease can result from dampness and fungi in the home or workplace. Recognizing that dust mites in damp environments explains some of the relationships between dampness and respiratory symptoms. The causal relationship between the damp environment and health symptoms, including respiratory symptoms, headache, fatigue, and recurrent infections, is less understood. Mold seems to represent part of the explanation. The guidance focused its analysis on the effect of mold in the indoor environment and the relationship between exposure to mold and mold spores on occupants' health. In presenting the guidance, the authors recognized that other microbes, including bacteria, gram-positive, gram-negative, and mycobacteria, grow in indoor environments and can contribute to occupants' health systems. Recent work in Finland identified bacterial species growing with mold that could also produce toxins. So, in conclusion, nobody really knows what causes a sick building. Nobody really knows if it's the mold or the bacteria or a combination of both. It is worthy of review and investigation, and the information contained in the guidance as well as information from the EPA should be studied before any conclusions are made or anyone litigates against others for causing injuries due to mold, fungi, or bacteria. This video was adapted from my newest book on mold, the Mold and Fungi Handbook, which is available both as a Kindle book and as a paperback from Amazon.com. It is also available with detail from my website, Zalma.com, by clicking on the link to the Insurance Claims Library. If you found this video to be interesting or of use to you, please refer it to your colleagues. It's free. And if you found it useful, please subscribe to my YouTube channel, my Rumble channel, and my blog so you can learn about future videos and blog posts. Thank you for your attention.